Hello, my name's Dr. Nick Burgess. I'm a gastroenterologist at Westmead Hospital in Sydney, Australia. On behalf of the co-authors of the Australian Multicentre Endoscopic Mucosal Resection Study, I'd like to discuss our paper, Risk Stratification for Covert Invasive Cancer among Patients Referred for Colonic Endoscopic Mucosal Resection, a large multicentre cohort, which will be published in an upcoming issue of Gastroenterology. One of the key issues that's encountered when assessing large colonic lesions for resection is deciding whether the lesion contains cancer. This assessment is critical as it determines the resection approach and management of the patient. For lesions with overt or obvious endoscopic signs of deep invasive cancer, endoscopic resection is not recommended and surgical resection is favoured unless there are major comorbidities that preclude surgery. Cancer invading more than 1 millimetre into the submucosa is associated with higher rates of lymph node metastasis, so even if endoscopic resection is successful, surgical resection and removal of local regional lymph nodes is still typically required to stage disease and reduce metastatic spread. If there are no obvious features suggesting cancer, then endoscopic resection is the best primary approach as it's safe, efficacious and cost-effective. In our practice, we noticed that some lesions without overt endoscopic signs of cancer still turned out to have cancer on pathological assessment. Even though EMR is an excellent tool for resection of the majority of colon lesions, it may be that some of these lesions with T1 cancer, which is superficially invading the submucosa, or SM1, may have been cured if resected by ESD. This is generally a small proportion of patients. In Western colorectal ESD studies, only 2 to 3% of patients referred for ESD actually avoid surgery and have a curative resection. In Japanese cohorts, it's more like 7 to 10%. ESD is time and resource consuming, has a higher rate of perforation, and there are only a limited number of trained endoscopists who can perform it. It's therefore important to try and optimize case selection to limit risk, but to also maximize cure. There are some existing endoscopic predictors of submucosal invasive cancer which include a Kudo-5 pit pattern or a depressed Paris-2C component to the lesion. These features are specific, but they have poor sensitivity, meaning that if the signs are absent, then there are still a good number of lesions that may have cancer within them, but this is not obvious endoscopically. These lesions may also be the ones that have a small focus of superficial cancer which may actually be cured by ESD. A tool to stratify risk of cancer and help make a decision on the best treatment approach would be very valuable. In this study, we wanted to define the key risk factors for submucosal invasive cancer in a large, prospective, multi-centre, intention-to-treat cohort of lesions referred for EMR. A number of tertiary centres and endoscopists across Australia were involved, meaning that the results represent a real-life take on how to assess risk of cancer in large colonic lesions. We performed multivariable analysis to determine the strongest predictors of cancer across all lesions, including adenomas and serrated lesions. The strongest predictor was a Kudo-5 pit pattern with an odds ratio of 14.2. A depressed or 0.2C component to the lesion was also an independent predictor of cancer. Separately to these overt cancer, 4 other key variables, location in the rectosigmoid, increasing size, Paris type and surface morphology, had the strongest independent associations with an elevated risk of cancer. Consistent with prior studies, our analysis of Kudo-5 pattern showed that it had a specificity of 97%, but only 41% sensitivity. There were still many lesions without overt features which harboured cancer despite careful inspection. So how do you decide which of the remaining lesions may contain what we ended up terming covert cancer? If a lesion has a particularly high chance of a covert cancer, then it may be more suitable to be resected by ESD. To examine this, we excluded lesions with overt features of cancer from the analysis, as well as excluding serrated lesions, as most have a typical endoscopic appearance and a low risk of malignancy. We performed multivariable analysis and found that size, location in the rectosigmoid, and combined Paris type and surface morphology allow accurate stratification of cancer risk in large colonic lesions. What this means is that you can simply group lesions by their gross appearance and location. Distally located 0,1s and 0,2a plus 1s non-granular lesions have a high risk of cancer, whereas proximally located 0,1s granular or 0,2a granular lesions have a very low risk. We also found that most colon lesions have a low risk of cancer overall. Around 75% had a cancer risk of under 5%. 0,2a granular lesions in the proximal colon have a particularly low risk of around 0.7% and are very amenable to EMR. High-risk lesions such as distally located 0,1s and 0,2a plus 1s non-granular lesions comprise less than 10% of total lesions, but often have a cancer risk exceeding 15%, even without obvious features endoscopically. These could be resected by ESD, and their location in the rectum and sigmoid means that ESD is technically less challenging and the risk of perforation is lower. The described system is simple and easily applicable in clinical practice. It's pragmatic and readily adoptable using existing assessment tools which are readily available to every endoscopist. It's derived from prospective multi-center data. It helps endoscopists to grapple with the fact that the majority of colonic lesions encountered in a Western setting in particular will be low risk, but that a few lesions may benefit from more advanced resection techniques. Endoscopic resection strategy decisions can be guided by these risk assessments, and we hope that this simplified tool will make it accessible to all who perform colonoscopy.